Impact of aortic size height index on midterm survival after thoracic endovascular aortic repair. Have no disclosures. Size criteria for thoracic endovascular repair are not as clearly defined as for infrarenal AAAs. Natural history of descending thoracic aneurysms has shown some cutoff for rupture. But the general size recommendations for aortic intervention can be made more precise using a complication risk nomogram based on aortic size and patient height, like this nomogram from the Yale group in an aortic ascending aneurysm study. Also, they identified that high alone was simpler, and comparing using the aortic size index and the aortic height index, it was better for predicting death and for predicting aortic-related death. So indexing the height of the patient to the thoracic aortic size may help to identify thoracic aneurysm patients who do not meet the current threshold for surgery. So the aortic height index is simple. You use the aortic diameter in centimeters and the height in meters. So using the Vascular Quality Initiative database, patients who underwent TEVAR in zones 3 to 5 with intact descending thoracic aneurysms were examined between 2003 and 2020 and stratified by the aortic height index in 3 groups. Cox proportional hazard ratio and survival models were used to estimate the AHI impact on the all-cause mortality, and the ROC curve was used to determine the cutoff of AHI at 3-year mortality, and also the area under the curve was used to compare diameter with the index. In the preparative demographics, we found that the third group had was older, had a diameter bigger, and the height was less compared to the other 2 groups. On the Kaplan-Meier survival analysis at 3 years, we found that aneurysms with aortic height index more than 4 had the worst overall survival compared to the other groups, and there were no differences between men and women. There were no gender differences between aortic height index groups also. We did a secondary analysis with the aortic-related mortality, showing that the third group had a worse survival at 3 years. In a separate analysis, we compared the aortic diameter versus the AHI, and AHI resulted in a slight greater ROC area. It was statistically better than using the aortic diameter alone, like shown in this figure. Also, we identified that AHI index cutoff point for the repair in terms of better survival was less than 3.8, and that 32% of the patients who underwent TEVAR had aneurysms larger than this criteria. Also, we were able to develop this nomogram for descending thoracic aneurysms. As a conclusion, height does not change significantly during adult life. AHI provides an individualized risk classification in patients with thoracic aortic aneurysms and may help to identify patients who do not meet the current threshold for surgery. Also, this is a retrospective study, and patients already had a repair. There is a correlation between higher AHI and decreased survival. Having said that, AHI may be more reliable index than aortic diameter alone, irrespective of gender, for degenerative aneurysms. Further studies are needed to determine the threshold for surgical treatment based on AHI. Thank you so much.